Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from ResMed.
Hello, I'm Dr. Chuck Vega, and I'm a clinical professor of family medicine at the University of California, Irvine, where I also serve as assistant dean. Welcome to this program entitled Enhancing Primary Care Confidence in Managing OSA in Patients with Comorbidities. I'm delighted to be joined today by a real expert in the field. Dr. James Hertigan is a professor of medicine and section and medical director at the Rush Sleep Center at Rush University Medical Center in Chicago, Illinois. Jim, it's great to see you.
Thank you. Great to see you.
So just to set the tone, we're going to be talking about the epidemiology and burden of obstructive sleep apnea, or OSA. We're going to be talking about how important it is to identify OSA early and how primary care can play a critical role in that identification. So Jim, let's start with the definition of symptoms and how we should be looking for OSA.
Sure. Symptoms or a bed partner often drives an evaluation. So often it's relating to loss of focus or concentration or more fatigue during the day. Of course, loud snoring is associated with airway closure, but also forgetfulness, daytime sleepiness, sleepy when you start driving, or sleepiness after work. So a constellation of many symptoms can occur and affects different people differently.
Right. And I really do see that burden. It's a wide spectrum in terms of how it can impact folks in terms of their daily function, their risk for things like accidents, and especially in my practice, worsening of chronic disease. I work in the biggest safety net clinic here in Orange County, California, and I see folks with high rates of obesity, type 2 diabetes, hypertension, atrial fibrillation, heart failure. All of these things can be complicated by OSA and actually can be provoked by OSA. And many of them are also working multiple jobs, and they have other risk factors for poor sleep or sleep fragmentation, such as mood disorders. So it's a really complicated process, but I know, like a lot of folks, unfortunately, I'm not recognizing enough OSA in my practice. And so that's why I think it's important to think about epidemiology. And Jim, I know that's something you're very familiar with.
Sure. And I think in your practice, if you think it, test for it because the prevalence is quite high. In the general population, and this is data from a number of years, decades ago, actually, it was thought that 5% of women and 14% of men are affected by sleep apnea. But that is a changing incidence over time. And as we age, our incidence increases. There are certain high risk populations, such as minority groups. And then you already mentioned a number of comorbid health conditions, such as cardiovascular disease with prevalences of up to 60%. The atrial fibrillation has a strong association with sleep apnea, especially recurrence, but also diabetes and obesity. So, for example, up to 46% of obese women and 77% of obese men may very well have sleep apnea. So the question really is, why don't we think about it more? First of all, I think patients often, as you described, are not getting enough sleep. They're working multiple jobs. They're stressed, and they think feeling not normal is their new normal. Feeling tired, feeling exhausted, they think it's due to other things. But up to 80% of individuals with moderate sleep apnea are still undiagnosed. And many do not report sleepiness. They might report either fatigue or focus, concentration, forgetfulness. Uh, but maybe sleepiness is less of a concern for them because they've been living with that for a long time.
I think that absolutely we see some of those chronic illnesses and some of the problems I described really briefly, but maybe you want to go into maybe a few more details about some of the complications of OSA. I really like what you said about if you think about it, screen for it. We don't have national guidelines right now saying every adult should be screened, but folks at risk or folks with symptoms should absolutely be screened. And I think you have some pretty good insights as to why.
Sure, and often, especially in primary care, you're limited by how much you can do in a visit. And often patients aren't going to volunteer the associations of sleep apnea, like, well, I just got into two fender benders, or I fell asleep at a stoplight and bumped someone else's bumper. They usually don't talk about that in clinic. But there might be conditions such as work performance or loss of job or absenteeism because of just not feeling well, especially today, which is daylight savings time, and you're sleep deprived a little bit, and it's a Monday, and there's a lot of absenteeism going on today, probably. But also thinking about an obese type 2 diabetic with cardiovascular disease, very high prevalence, perhaps up to 50 to 60%. As we age, the concerns for dementia and Alzheimer's disease become greater. You might encounter acid reflux or gastroesophageal reflux and pharyngitis, which can be commonly associated with sleep apnea. Then, of course, quality of life and what we can do to impact both family life, work life, and personal life.
Right. And when you were just describing just the many effects and other illnesses associated with sleep, it just made me think about broadening the lens. Obstructive sleep apnea, incredibly common, unrecognized, as you mentioned. But there's so many other factors that go into sleep. So I think just asking about sleep in general can unlock so many other health issues. And that's a great way to move patients forward because when you're not sleeping, you're not going to live up to your full potential. I think one thing that we have in primary care is that oftentimes I'll be taking care of not just the person at risk for OSA, but I might be caring for their sleep partner as well. And the elbow sign, which I'm sure you're pretty familiar with, Jim, is a very sensitive sign for obstructive sleep apnea. How does the elbow relate to obstructive sleep apnea? It's, hey, wake up, you're snoring really loudly. If you get a negative report from a sleep partner, the chance of them having sleep apnea go down. But we'll talk about some simple tools that we can use. And you're right, we have limitations in primary care practice, but these tools are fairly rapid and can give us a good idea as to who might be suffering from sleep apnea, but not necessarily know it. So I find that the advantage is that we have in primary care, knowledge of family and perhaps a sleep partner who can report what's going on at home. I think another advantage, we do know there are other comorbid illnesses, and we also know what we may be prescribing for them because what we may be prescribing them could actually be harmful, particularly if it's sedating and they have OSA. So always keeping an eye on med list and trying to trim medications that could be harmful is very important, I think, as we move forward. So I mentioned some of the screening tools. Jim, do you have some favorites you'd like to share?
Yes, even in our sleep clinic where patients with a high prevalence are already coming in, I think the stop bang is a very useful screening tool. Some of it is self-report, some of it relates to obesity, gender, age, neck circumference, and so those are some of the things that can be easily measured within the clinic. There's also a sleepiness scale called the Epworth Sleepiness Scale, and that might not be just sleep apnea, might be, hey, I'm a shift worker or I'm sleep deprived. And it's a scale to assess sleepiness in passive situations. Of course, when you have these risk factors of obesity and a family history, craniofacial abnormalities such as a recessed jaw, heart failure, atrial fibrillation, stroke, type 2 diabetes, even polycystic ovary syndrome in younger women, acromegaly or Down syndrome, all these can be risk factors for sleep apnea.
Yeah, and I'm kicking myself a little bit for not mentioning, as I was talking about medications, think about other things that patients may be using to medicate themselves, including alcohol and other drugs. And use of caffeine is also a factor as well. So this was just the tip of the iceberg in module one, but Jim, you got us off to a great start. Thank you so much for participating in this discussion.
Thank you.
And thank you all in the audience for participating in this activity as well. Please continue on now to the next module of this program. We know that everybody's really busy. Hopefully, you found this episode helpful to your practice. Be well, everyone. Hello, everyone. I'm Dr. Chuck Vega. I'm a clinical professor of family medicine at the University of California, Irvine, where I also serve as assistant dean in the School of Medicine. Welcome to Module 2 of this program entitled Enhancing Primary Care Confidence in Managing OSA in Patients with Comorbidities. And we have an excellent expert to join me today in this conversation on a very important subject. Dr. Sophia Khan is an associate professor in the Department of Family and Community Medicine and the Department of Neurology at UT Southwestern Medical Center in Dallas, Texas. Sophia, welcome.
Thank you for having me here, Chuck.
Yeah. In this module, we will discuss the impact of untreated OSA, particularly among patients with comorbidities. There's almost so many different types of comorbidities that we can see with OSA. It can be difficult to know where to start. So maybe, Sophia, you could walk through some of the common consequences we see associated with OSA.
Sure. So some of the more common symptoms that we see with untreated sleep apnea are excessive daytime sleepiness, excessive tiredness and fatigue, and then the bed partner disturbance because of loud snoring. These are some of the very common ones presenting to our sleep clinics. I like to start basically from the head to toe. So, looking at the neurologic system, impaired cognition, attention deficit disorder, mood disorders, anxiety, depression, coming down to the cardiovascular and respiratory systems. You can see anything from arrhythmias, atrial fibrillation, paroxysmal atrial fibrillation, tachycardia, bradycardia, and even some heart blocks. And then sometimes when patients have had ablation, say, for example, for their atrial fibrillation, if they don't treat their obstructive sleep apnea, they can go back into the abnormal rhythm. High blood pressure, increased risk for heart disease, stroke, atherosclerotic disease is also very common in patients with untreated sleep apnea. Pulmonary hypertension, exacerbation of COPD, and asthma, or respiratory failure because of those underlying conditions, and untreated sleep apnea can also be seen, not very commonly, but yes, we do see frequently patients that are admitted to the ICU. They will have underlying untreated sleep apnea that then exacerbates their pulmonary conditions. Looking at some GI issues, GERD is very common in patients with untreated sleep apnea, sometimes also presenting as chest pain or atypical chest pain, particularly in women. Other system involvement, it also affects the health in the different gender roles. For example, erectile dysfunction, nocturia, and vasomotor symptoms like nocturnal hot flashes are also very commonly seen in patients with untreated sleep apnea. Some other consequences of untreated sleep apnea include physical functioning and impairment because of non-restful sleep, vitality, general health, emotional health, and then driving impairment. That's the big one. Feeling sleepy while you're driving, it's a public health risk.
Yeah, there's so much, and thanks for elucidating it. And I think that the important thing here is you really mentioning the risk of OSA for these other important disease states, and how it can exacerbate those disease states. But when you treat OSA, many of these can get better. So for me in primary care, if I'm treating their diabetes, their heart failure, their high blood pressure, etc., and their depression, and they feel fatigued all the time, I'm probably not going to get to the heart of those issues in terms of treatment and improving the way they feel, and also their risk factors for major future health events, particularly cardiovascular events, without treating the OSA. Is that about right? And do you see it the same way? There really is kind of like a bidirectional relationship between OSA and many different chronic illnesses?
Absolutely. In fact, a lot of times patients present to our clinics and they're like, I saw my primary care physician or my cardiologist for resistant hypertension. I don't know why they've sent me for a sleep study. How is that related to my blood pressure? And when you
Right.
explain to them the increased, sympathetic activity with untreated sleep apnea, uh, which leads to then tachycardias, increased blood pressure, or untreated or resistant hypertension, and in some cases, patients will have very high morning blood pressures and rest of the day their blood pressures are near normal. When primary care physicians see these patients in their clinics with elevated blood pressure, we keep going up on their blood pressure medications without realizing that treating their underlying sleep apnea will help stabilize the sympathetic tone in their system. and will help reduce these blood pressure fluctuations for patients with resistant hypertension. Diabetes, a lot of times patients have uncontrolled diabetes, and the underlying cause is the untreated sleep apnea.
I think it's very important, though, and also maybe just to pull back a little bit, while OSA is one of the major contributors in my practice in terms of all of those treatment-resistant conditions or severe conditions that you mentioned, really any sleep disorder, any lack of sleep due to a mood disorder, etc., is going to really set you back in terms of trying to achieve optimal health goals for patients. So sleep really is something we should be taking into account more effectively, maybe getting a report from a patient. And if you can, getting a report from a sleep partner would be really valuable as well. I think of sleep as its own area where it can contribute positively or negatively to health. And then mood is also really important. But OSA is also associated with mood disorders as well, correct?
Absolutely. So, for mood disorders, I like to explain to patients that we have these neurochemicals or neurotransmitters in our brain, the serotonin and dopamine, and all of these have to be refurbished and replenished at night when we are sleeping. And when there is constant sleep disruption because of either hypoxia or upper airway obstruction, then the balance of these neurochemicals is disrupted, and that leads to anxiety disorders, mood disorders, depression, tiredness during the day, fatigue, and these can then complicate the treatment of their underlying mood disorder. So it's really important to treat the sleep and improve the quality of their sleep to help improve their mood disorders and psychiatric conditions. And multiple studies have found a significant correlation of untreated sleep apnea with worsening of depression, anxiety, and also triggers for bipolar disorder, just because patients are not able to maintain sleep or get restful sleep.
Yeah, absolutely. So, how should we talk to our patients about OSA?
So I like to correlate their medical conditions with their sleep. I like to just simply ask, tell me about your sleep. Are you getting enough sleep? How is the quality of your sleep? Do you snore? Do you wake up gasping for air? Do you have acid reflux? Do you toss and turn in your sleep, or have you been told that you snore loud and you and your spouse sleeps in a different room, for example? I also ask about other common symptoms of sleep apnea, like recurrent sore throat or congestion or exacerbation of their underlying conditions, like we already discussed, asthma, COPD, high blood pressure. When these are uncontrolled, I bring up their sleep, and then I recommend to them that evaluating the quality of their sleep and whether they have sleep apnea or not will really help improve management of their other comorbid conditions.
For sure. Excellent. So we're going to talk more about managing OSA in the next module, but any special pearls you want to share with our audience about managing comorbid conditions in the setting of sleep apnea?
So the common one, let's start with weight management. When I'm evaluating patients for sleep apnea, I also look at their BMI. And I mentioned that weight contributes to sleep apnea, and making sure that you don't gain any weight. Or if you're trying to lose weight, we can help you with losing weight so that your sleep apnea can be better treated. Other things, like when I'm treating somebody with 2 or 3 different antihistamine medications for their allergies, I bring in sleep apnea. I explain to patients that there is a lot of friction in the back of their throat when they have untreated sleep apnea, and without treating the sleep apnea, we won't be able to treat their allergies. So bringing up these things, and I like to plant the seed. I discuss sleep in the first visit, then I bring it up again until the patient asks themselves, hey, can I get a sleep study? And that's a win because that patient is ready for treatment.
That's a good point. Yeah. So they're very motivated at that point. From my perspective, we also very much want to do no harm. So take a look at the med list, avoid those sedating drugs, and try to replace them with drugs that could, not be potentially harmful in terms of weight gain, but also that might promote more sleepiness, tiredness, and then create even more problems and risk for accidents. Sophia, this was a great discussion. Thank you so much for some wonderful advice for us.
Thanks for having me here.
And thanks to our audience as well. Hopefully you found this module helpful for your practice. Please continue on to the next module in this program, and be well, everyone. Hello, I'm Dr. Chuck Vega, and I'm a health sciences clinical professor in family medicine at the University of California, Irvine, where I also serve as assistant dean in our School of Medicine. And I'm very excited to welcome you to now Module 3 of this program on enhancing primary care confidence and managing obstructive sleep apnea in OSA. I'm delighted to be joined by Dr. John Carter. He's the director in the Center for Sleep Medicine and Division of Pulmonary and Critical Care and Sleep Medicine at Metro Health System in Case Western Reserve University School of Medicine. So, welcome, John. Thanks for being here with me today.
Thanks so much for having me.
So, in this module, we are going to be talking about management strategies for OSA. And we're particularly going to focus on those patients with comorbidities, which is certainly the majority of patients in my practice. Folks with chronic illnesses such as hypertension, obesity, and type 2 diabetes. And then we're going to be focusing mostly on the use of continuous positive airway pressure, or CPAP, as a treatment because it's really the most established measure in terms of treating OSA. And I think it's really has some of the best evidence of outcomes. So, John, maybe that's a good place for you to jump in. With CPAP, what kind of benefits can patients get?
Well, the good news is, CPAP really works. It's a highly efficacious therapy, and it is still nowadays the gold standard of treatment for obstructive sleep apnea. So we've got lots of evidence now that CPAP can make a big difference in certain areas, both in terms of the symptoms that people are experiencing, as well as various health consequences, various comorbidities. Probably the best evidence for CPAP's utility is around the symptom of sleepiness. We see big improvements in people who are sleepy once they go on CPAP therapy. Their sleepiness improves significantly. And we also have very strong evidence for hypertension. People with hypertension, especially drug resistant or refractory hypertension, tend to have a really good improvement in their blood pressure, systolic, diastolic, and 24-hour with effective CPAP therapy. We're getting accumulating evidence for additional metrics, both in terms of the symptoms and other health issues. For example, people with diabetes will often notice that their glycemic control improves once their sleep apnea is treated. On average, that's maybe 0.2, 0.3% in terms of their hemoglobin A1C. If they're really compliant with their CPAP, the data shows that could be a 1% drop in their A1C. A really significant improvement. And then if we look a little longer term, people who are using CPAP to treat their apnea have lower risks for cardiovascular and other kind of cardiopulmonary adverse outcomes, both in terms of morbidity and mortality. And some recent studies have actually shown an improvement in all-cause mortality. Unfortunately, the wind's blow in the other direction as well, and some recent studies have shown that if you stop using your CPAP therapy, those risks go back to where they were at baseline. In other words, the treatment for the apnea is only conferring its benefit as long as you're actually using the CPAP.
Yeah, and that's something we're pretty familiar with, at least in primary care. You stop your diabetes, hypertension treatment. Unfortunately, it's rare to get cure. But I do love the fact that, as you described, there are multiple endpoints that can be improved because patients' motivations may be quite different for why they would want CPAP. So I think that a lot of times I will start with a patient and what their particular motivations are. And there is good evidence you can tailor your guidance to the patient based on their values and preferences, which is always a great place to start. Yet, we know that the rates of adherence to CPAP are low. This is something that I've noticed in my practice. And there was a study that looked at CPAP use in over 80 trials, and they found that overall, the average adherence to CPAP was well under 40%, 36%. And it didn't really improve despite 20 years where we have different types of devices now that are quieter and we might be able to, improve, say, humidification. And unfortunately, I think that's critical because there's a fairly linear relationship between how CPAP is used and those better outcomes. The more you use CPAP, the more you're adherent to it, the outcomes get better. Is that right?
That's absolutely right. And I think you're hitting on a really important point, which is there's always technological advancement, but at a certain point, you're going to hit a ceiling. And for the last 20, 25 years, really since the early 2000s, the rate of CPAP non-adherence has been stubbornly stuck. And that's despite all of the advancements in technology, in patient-facing applications, in things that we can do in our counseling. I think the good news is there are some evidence-based strategies that we can use as providers in the office, that our partners in medical equipment delivery can use to optimize therapy. I will say one strategy that I find very effective, as you mentioned earlier, is tailoring the intervention to the patient and really emphasize to that patient, hey, you're in control here. I want to get you better, but I want to do it on your terms as best I can. Emphasizing to patients that there are alternatives, having them understand the reason why I want them to get on treatment, whether it's to help them feel better or to reduce their risk of various comorbidities or perhaps specific comorbidities, is really, really helpful. And I think at the end of the day, patients appreciate data and they appreciate control.
And I guess another point would be you really want to do that right from the outset. So you have a good clinician patient relationship because it's that first month of CPAP treatment that has been shown to be associated with longer term adherence. And that's why I think primary care plays a really important role because we're much more likely to be seeing them early and often in their disease course. Moving ahead, though, not everybody is going to feel that CPAP is right for them. Some patients will try. I will certainly have them try it several different times. I'll work with them, but it's just not the right fit. What do you recommend in terms of other forms of therapy for OSA?
Well, generally, I like to think about adjunctive therapies and alternative therapies, and they both play a role. The earlier we introduce these, the better. I think if patients understand that they have options and alternatives, they're more likely to come back. If they think that the CPAP that I'm offering them is the only option, I'm a lot less likely to see them again if they're struggling with it. But if we start with the adjunctive treatments, things that can improve apnea or make the treatment easier or more tolerable, we're talking about things that we're recommending really to all patients or most patients with sleep apnea. Number one is healthy weight. There is a well documented relationship between BMI and sleep apnea, and it goes in both directions. Weight gain leads to more severe sleep apnea. Weight loss and approaching a healthy weight leads to reduced sleep apnea. And so we try and make a point of advising healthy weight in all of our patients who are overweight or have obesity. Couple of other things I think are worth talking about to just about everybody. One is that a lot of people have what's called positional sleep apnea. The force of gravity pulls on the soft tissue in the back of the throat. When we're supine, we tend to have worse obstruction when we're on our back, whereas we often have more mild obstruction when we're on our side or even our stomach. Now, that doesn't mean that sleep apnea is gone when you're on your side of your stomach, but you can often alleviate or ameliorate a good proportion of those symptoms, which means if somebody is using CPAP and they sleep on their side, they might not need as high pressures, or they might not get as much leakage from the mask, and therefore that therapy is much more tolerable. The other thing to talk about is we want to make sure that patients are avoiding things that can make their sleep apnea worse and their sleep worse in general. And the big one here is alcohol. Little glass wine with dinner may be okay. But a nightcap or more heavy drinking in the evening can have really deleterious effects on respiratory control, on upper airway musculature that should be holding the airway open. And it can also cause a lot of sleep fragmentation, particularly in the second half of the night. That is exactly the time of the night when you should be deeply asleep and getting your most restful sleep. The other thing I think is really important in adjunctive therapy is engage and empower bed partners. If the patient is lucky enough to have a bed partner to rely on, these are often the people who are kind of our best advocates and allies in ensuring good compliance with therapy. I'm sure you've seen this time and time again. They're the ones bringing the patient into the
They're
office.
driving it.
Yeah, so that bed partner can be a very powerful source of motivation and compliance.
Yeah, I thought, when you said advocates, I thought you were going to jump right into enforcers because that's absolutely what I find a lot of those bed partners are. But it's very worthwhile. Again, I mentioned this in an earlier episode. Very important to get that history. So it can be great as a screening tool, and it can also be really helpful to have someone there to just kind of coach them, lead them, cheer them on. And yeah, always try to keep it positive and constructive. I will also mention the study with tirzepatide last year, looking at folks with OSA, where in the tirzepatide versus placebo group, there was significant reduction in the apnea hypopnea index, plus lower body weight, plus lower sleepiness scores, lower blood pressure. It's not really available in my practice for this particular indication with obesity and OSA, but I'm hoping that changes coming up soon. But there are other devices, there are mechanical devices, and maybe you can address those and where they fit into therapy for folks with OSA.
Sure. Yeah. So at this point, we're talking about alternative therapies. In other words, the CPAP was tried and either isn't doing the job or it's just not the right fit for that patient. And here again, we really try and emphasize the many alternative options. Um, I would say most of my patients, if they're thinking about an alternative, they're going with some type of intraoral device. There are lots of different names for these oral appliances. These are different than the kind of bite guard or night guard that you would get from a standard dentist or over the counter. These are actually mandibular advancement devices. So they're moving the lower jaw forward in order to open up the airway. Access to these is a little challenging. The especially trained dentist, a sleep trained dentist, is the one who should be making these, overseeing their fabrication and adjustment before they send them back to you to kind of make the final determination on improvement. Insurance coverage is another barrier, but these are highly effective, primarily for patients with mild to moderate sleep apnea. So the rule of thumb that I tell patients with oral appliances, it's going to cut your apnea by about 50%. As you mentioned, tirzepatide was approved a few months ago by the FDA specifically to treat moderate to severe obstructive sleep apnea in patients with obesity. We're starting to see a lot of patients really coming out of the woodwork asking for these prescriptions. And these are patients with already diagnosed apnea or some folks who don't even have a diagnosis yet. They just suspect that they might have it. And I think we're definitely going to see movement in this area, although access is very limited right now. For more significant apnea, severe apnea, we'll often talk about sleep surgery, many different surgical approaches that are available now. Some of these are soft tissue surgeries where usually it's ENT. Is removing excess tissue in the oropharynx, or they're otherwise moving the soft tissues around to open up the airway to increase the airway caliber. And these have reasonably good efficacy for the right patient. Finding an ENT or sleep surgeon who is very experienced with this is absolutely key. And then finally, relatively new therapy is something called hypoglossal nerve stimulation. This is an implanted device that looks a lot like a pacemaker, and this works at night to stimulate a nerve that controls the tongue muscle to open up the airway at night. Again, very efficacious therapy for patients who are good candidates.
Yeah, I think it runs the gamut. And we can't forget about, those basic issues like programs to maintain or to attain a healthy weight, and just having good sleep hygiene in general. Those are part of it as well. And I have patients who do go all the way from those very basic lifestyle interventions all the way to potentially needing surgery. And so it's great we can support them at every step of the way, although it does get difficult, as you mentioned, to find access to specialized services. By that time, they're probably in a very specialized center such as yours. Thank you so much for this great discussion. I learned a lot, and hopefully our audience learned a lot. John, it was a real pleasure.
My pleasure. Thanks for having me.
And thanks to all of you and our audience for participating in this activity. Take care, everyone. Hi, I'm Dr. Chuck Vega, and I'm a clinical professor of family medicine at the University of California, Irvine, where I'm also serving as assistant dean. Welcome to Module 4 of this program on enhancing primary care confidence in managing obstructive sleep apnea in folks with comorbidities. I'm really excited to be joined by a true expert today and a national leader in this subject, Dr. Joyce Lee Ionati, who is a professor of neurology and director of the Sleep Center, as well as director of the Petsnick Stroke Center in the Barrow Neurological Institute in Phoenix, Arizona, I should also mention that she is the vice chair in the sleep section of the American Academy of Neurology and director of the board of directors for the American Academy of Sleep Medicine Foundation. Dr. Lee Ionati, it is really an honor to work with you today.
Likewise, Chuck. Thanks so much for having me.
So in this module, we're going to be looking at some real world challenges. We're going to make this very pragmatic, hopefully, for our audience. In my personal practice, obstructive sleep apnea is incredibly common overall. It affects about 1/4 of U.S. adults, roughly. But I also see a lot of barriers to my patients recognizing the symptoms, certainly getting testing done, and then also following up through treatment is a real challenge. Now, I recommend CPAP all the time to my patients, I prescribe it. But we know that over the course of a year, most folks who initiate, if they are willing to initiate CPAP treatment or ventilatory treatment for OSA, they're very likely to stop it, unfortunately. So it's very important to get that treatment on board, help them succeed, particularly at the beginning, because folks who can initiate treatment and continue it for those first few months are much more likely to succeed in the longer term. And then we've covered in other modules the ill effects of untreated obstructive sleep apnea with fatigue and accidents and hypertension and atrial fibrillation and stroke. So we know about those potential risk factors. And so I'm working hard in my practice to mitigate against those risk factors. I'm trying to treat their mood and try to achieve healthy sleep, but I'm also treating their hypertension, their diabetes, their existing heart failure to try to maintain the most optimal functional level I can, and also avoid terrible events like hospitalizations and ICU admissions as well. So, even though I might be referring to sleep medicine to diagnose OSA, I'm always there with the patient as a primary care. But I think it's also important to have a real discussion when I screen patients, particularly when they're at risk for moderate to severe obstructive sleep apnea. I want to talk about the steps in diagnosis because a questionnaire is not a diagnosis. And then beyond that, what the treatment is. And unfortunately, getting sleep studies is a real challenge in my practice. There's just not enough sleep medicine providers nationally and in my area as well. So I don't know, Joyce, I'm going to bring you in as I'm whining here. How do you overcome this?
Chuck, I'm so glad we're talking about this topic because it is so near and dear to my heart, both personally after being diagnosed with sleep apnea myself, and then professionally because I see it every day. I see people completely turn their lives around once it's treated. So, we can talk about, first of all, the physician shortage. I love the title of this, which is How to Empower the Primary Care Physician. With the physician shortage, we know that there just are not enough sleep medicine specialists to diagnose every sleep apneic out there. In fact, you may be really astonished to hear that more than 80% of people are undiagnosed with moderate to severe sleep apnea. And moderate to severe sleep apnea is where all those horrible things come about. So I love the fact that we're talking about how you and I can partner, me as a sleep specialist, you as a primary care doctor, on how to reach more patients and cast the net even wider. The first point I should talk about is just to ask about sleep in your practice, which I know you already do, but we still are not having enough people ask. And so I will be alluding a lot to my favorite questionnaire, which is called the Stop Bang questionnaire. It's easy to teach and it's a wonderful acronym. So STOP is the subjective complaints. S is snoring, T is tired, O is observed apneas, where people see you stop breathing, and P is pressure, so blood pressure issues, even if you have controlled hypertension on medications. And then BANG are the objective parts. So BMI greater than 35, age greater than 50, N is neck circumference, so greater than 18 inches or 40 centimeters, and G is male gender. And just by documenting the stop bang score, greater than 3 will justify a home sleep study at least, and maybe an in lab sleep study if the patient's more complicated. But as simple as that, give it to your medical assistant, have the patient fill it out even beforehand. It literally takes a minute to do. I also want to touch on the fact that telemedicine was a silver lining with the COVID pandemic. I'm based in Arizona, but I can see patients 3, 4 hours away and even across state lines if needed. So this has kind of broadened our reach. So I love the fact, Chuck, that you Ask your patients about sleep medicine, about their sleep in general, and that you partner with sleep specialists, but want to reiterate what you've already said, which is there's just not enough of us.
Right. And so it really does come to us as PCPs. We're that point of first contact. And so asking about sleep is a good idea, even if you're not suspecting sleep apnea, because it has so much to do with wellness. It's really hard to achieve good outcomes in those chronic illnesses like hypertension or depression if you don't get adequate sleep. I think another advantage we have is that we often are treating the patient and their partner. So we can get an informant involved. And that elbow sign associated with obstructive sleep apnea, if you just need a really quick screen, is a very good and very specific sign. When the partner has to elbow them because they're snoring too loudly and they're worried about their breathing, that is definitely a time to inquire more about risk factors for obstructive sleep apnea. But again, it's taking time in a busy practice to make that change. I think it's completely worth it. It's time well spent. The stop bang is great for primary care because it is really fast. But then there's a challenge of, I think, of getting the patient involved and invested. I find that maybe the blood pressure isn't going to be so motivating for a lot of my patients, but fatigue and having more energy during the day, I think that is a big motivator. So they'll be more excited about getting the diagnosis made. And then getting treatment like CPAP on board, I think that's very important as well. But I try to preload this before I make the referral for polysomnography so that the patient knows there's a fairly good likelihood you can have at least moderate OSA, and we're going to recommend a treatment for that. What's your approach?
Chuck, I love the fact that you have this rapport with the patient and the entire family, and you're already introducing it. You just make my job a lot easier as a new person to the care team. I love the fact that you talked about the sleep partner. The bed partner is usually the reason why the patient makes it into my clinic or your clinic because they're worried. So, collateral information from the bed partner, even from the kids, if they tell you you stop breathing and that your snoring is shaking the walls, listen to them. It's very likely that you have sleep apnea. So the whole family can get involved. I've seen it where we treat the patient and then the children clean up their sleep hygiene. So it really does benefit the entire family. I love the fact that PCPs are now asking the question early on. It just makes our job easier and it's more likely to make the patient compliant with therapy.
Well, I think that brings up an interesting paradigm shift I've seen, particularly in the past 7 years or so. It used to be that sleep specialists would follow patients. I want, Joyce, you to see complicated patients. Maybe they have periodic leg movements and they've got also some other factors that are weighing on their sleep that make it really difficult to achieve optimal outcomes because there's a lot to tease out there. But for more straightforward cases of obstructive sleep apnea, getting that report, we recommend CPAP. Here's the settings that we recommend to start with. I'm fine now with doing that. That's not something I was doing 10 years ago. But because of that gap and the fact that patients might wait 6 to 9 months before actually getting in with a sleep specialist to talk about treatment, I'm taking that step forward. And then really trying to support them as best I can. But I'd love to hear more about some of your wishes from us in primary care, best practices that would really optimize their success once they start either through the diagnostic process or during the treatment process.
Everything that you already do, Chuck, is the only thing that we would love more primary care doctors to do, which is one, ask about sleep, do the stop bang questionnaire, get at least a home sleep study. So by the time they see a sleep specialist, we have a diagnosis and we can hit the ground running. We can get the CPAP started, leave the complicated cases definitely to me. I can't expect the primary care physician to take care of everything. So just getting the ball rolling is my ask, and that would just help us both contact more patients and see more patients efficiently and get them on therapy.
And once the patient gets started, hopefully they are feeling better. They see the positive results. Maybe their blood pressure comes down on CPAP, and I can always point that out as a sign that this is working. And then we just build on that success from there. My job is to keep working, not just on the sleep apnea, but those comorbidities. And then also, again, keep their family and their loved ones in mind.
Yeah, absolutely. And I just want to comment one more thing, Chuck. Sleep apnea is the root of all evil. Nothing's going to get better if you're not sleeping well because your brain is not getting enough oxygen. When I started CPAP therapy, which was not fun, it took me 3 weeks to get used to it. But as a migrainer, since the age of 12, 3 months after using my CPAP consistently, I haven't had a single migraine. So I personally have felt the benefits. And these are stories that I hear from my patients every day because it truly does work. It's the standard of care.
But there are some other barriers such as costs. And I don't know if you have any tips about ways to work either with third-party payers or folks who are underinsured or uninsured to try to get them the right treatment. What's your advice there?
CPAP can be expensive. So, Chuck, between you and me, when you look at the prices for CPAP, it can be $1,000, $2,000. But luckily, a lot of insurance plans, both Medicare and commercial, do cover CPAP and they offer even monthly plans. So some of my patients pay nothing. Other patients pay like 15 bucks, 50 bucks for a month, up to a year. And if you hold up your end of the bargain and you use it for at least 4 hours per night, you get to keep the machine. So you're paying actually a very small fraction of the cost as long as you're using the treatment. And very plainly, insurance companies know if you use your machine, you're going to stay out of the hospital. They're going to end up saving money, and ultimately, it saves lives. That's the whole message.
For sure. And it's interesting for your patients who are really struggling and really don't have any other resources. The Reggie White Foundation has been supplying CPAP machines for free for patients for years. So there's an application that's available online, and that could be a recourse as well for patients who really don't have a lot of other ways to go. Anything else before we close out that might work for PCPs and to help care for these patients more effectively?
Sure. So, very practical tips, put it in your smart phrase in your EMR. Make it a point to go down your checklist and ask about sleep. And it doesn't have to be just obstructive sleep apnea, even though that's most predominant and prevalent. Ask about poor sleep. Have your medical assistant or nurse give out the stop questionnaire while they're waiting. It's really easy to document in your note. And then align with your local sleep medicine specialist to at least get a home sleep study. The other thing I want to mention, which is really near and dear to my heart, Chuck, is I'm a program director for a sleep fellowship. And with this physician shortage, we need more people going into sleep. It's a 1 year fellowship. It really is multidisciplinary where sleep just affects every organ in the body. And we're looking for more people to train to add another tool to their toolkit to help the patient comprehensively. The last thing I want to mention is that we know that health disparities exist, especially with sleep apnea screening. So, African Americans are 2 times more likely to have severe obstructive sleep apnea compared to other races. And then there was the Hispanic Community Health Study that showed the prevalence of sleep apnea can be as high as 15%, but less than 1% of Hispanic patients are asked about sleep. So we still, with all of our efforts, we are still missing a lot of people and we need to do better.
And I think that has a lot to do with just having a regular place of care and folks who can work with patients over time, basically being a good primary care provider to individuals. And we have to recognize absolutely that if you have a low income background, if you have spotty care, sporadic care with a lot of urgent care and emergency care substituting for primary care, those folks are also at increased risk of undiagnosed OSA. So we should give them some special attention. And I think that's a great way to close out this conversation. We all should play a role in terms of screening, diagnosis, and management. We really want to take more ownership of this in primary care. I do see that evolving right now, and I think it's going to yield a lot better outcomes for our patients and our communities. Joyce, thank you so much for joining me in this discussion today. Thank you very much to our audience as well. We know you're all very busy, so hopefully you found this session pragmatic and helpful to your practice. Please check out the other modules in this series. And until next time, be well.
Thank you, Chuck.
Thank you.